Hello, and welcome to this Clinical Care Options Oncology podcast. I'm your host, Jervis Constanzo. In today's episode, we're joined by Dr. Jessica Lin from the Massachusetts General Hospital and Dr. Alice Shaw from the Dana-Farber Cancer Institute in Boston, Massachusetts. Together, they will be discussing the available and emerging clinical data in patients with recurrent ROS1-altered advanced non-small cell lung cancer. This episode is part of a larger educational program entitled ROS1 Revealed, a cancer conversation on the changing tide of non-small cell lung cancer treatment. For more information on Drs. Lin and Shaw, along with a link to the complete program, including downloadable slide sets and a clinical thought commentary, please visit the show notes for this episode. Now let's hear what the experts have to say on this topic.
The NCCN guidelines, recommendations for progressive ROS1 lung cancer, make a few important distinctions. First, is the disease progression symptomatic or asymptomatic? The pace of disease progression does influence how we think about the treatment options. Second, where is the disease progression occurring? Specifically, is the progression in the brain or extracranially or both? And then third, what is the pattern of progression in terms of the extent? Is it limited disease progression, just involving one or two sites of disease? Or is it more diffuse, widespread disease progression? Dr. Shaw, could you please comment here on how your approach in the clinic might be distinct based on the patterns of disease progression, limited versus more widespread?
Yeah, this is a really important point, Jess. I mean, we definitely have pretty extensive experience now with oncogene-driven lung cancers like ROS1, where there's more limited or what we call oligoprogression. So that's referring to progression of disease at one or maybe only a few sites while they're on TKI therapy. And for these patients, we know that the TKI is actually still controlling the bulk of disease. And so to maximize time on the TKI and clinical benefit the patient may be deriving, we often choose to treat the few sites of progressive disease with local therapy. And oftentimes that's radiation, I would say less commonly surgery, and that's then with continuation of the same TKI. And I think this approach can be quite effective in some patients. And so I would say, as you highlighted, whenever I meet a patient who's progressing on a ROS1 TKI, I always assess this issue. Is there oligoprogression? And if so, then which local therapy may be appropriate? Or is there more multifocal progression for which I really need to change the systemic therapy?
Thank you. In my clinic as well, we pay a lot of attention to that pattern of progression. And certainly in the case of oligoprogression, we consider local therapies. Now we're going to focus on the second scenario, which is where there is more widespread disease progression and switch in systemic therapy is warranted. There have been several next-generation ROS1 inhibitors developed, and these are aimed at overcoming mechanisms of resistance to the earlier generation TKI, but also at achieving hopefully better CNS penetration and activity and improving toxicity profile. Briefly, after first-generation ROS1 inhibitor, tumors may have developed resistance because of either on-target or off-target mechanism of resistance. On-target mechanism of resistance largely refers to acquired ROS1 kinase domain mutations on top of the original driver ROS1 fusion. And the most common one that is observed in the clinic is this ROS1 G2032R mutation. Next-generation ROS1 inhibitors have been developed to specifically overcome these ROS1 mutations, including G2032R, based on the clinical observations. We'll not be able to go into off-target mechanisms of resistance in detail today, but those are referring to alterations in pathways outside of ROS1, such as amplification in another gene called MET, which then results in drug resistance.
Yeah, I mean, I think for years now, many groups, including ours, have been obtaining repeat biopsies at the time of progression on TKI so that we can discover these mechanisms of resistance. And really importantly, we want to see if we can identify a new acquired alteration that could be targetable by an available targeted therapy or referral to a clinical trial. Originally, we did a lot of tumor biopsies at progression and then, of course, submitted the tissue for NGS. But I think more and more we have turned to liquid biopsies. Of course, these are non-invasive, allow us to still profile the circulating DNA to try to identify targetable resistance mechanisms. And so I would say that for every patient on ROS1 targeted therapies who's demonstrating some progression, at the minimum, I'm submitting a liquid biopsy and oftentimes in parallel, also considering a tumor biopsy.
Thank you so much for sharing those insights. So let's say a repeat biopsy is performed. If feasible, then what treatments can we consider after the first-line therapy? In the remaining few minutes, let's review the key data for ROS1 inhibitors that have shown activity in patients after progression on crizotinib or entrectinib, which are the two ROS1 inhibitors that have been around for a long time. The first drug we'll review is lorlatinib. Lorlatinib is a next-generation ALK and ROS1 TKI that is FDA approved for patients with ALK-positive lung cancer. It does not have FDA approval for patients with ROS1 lung cancer, but is included as an option in the NCCN guidelines. Lorlatinib has shown efficacy in patients with ROS1 lung cancer in a phase 1/2 study. So in patients specifically who've received prior crizotinib, the overall response rate with lorlatinib was 35%, with a median progression-free survival of 8.5 months. I should note, though, that lorlatinib does not have good activity against that ROS1 resistance mutation G2032R that we mentioned earlier. Notably, lorlatinib is a highly CNS-penetrant agent, and in this specific patient cohort, the intracranial response rate was 50%. There was an investigator-initiated study looking specifically at the efficacy of lorlatinib in patients who experienced brain-only progression on crizotinib, which is not an uncommon pattern of progression that we see with this non-CNS active TKI. So in this study, the best intracranial response rate achieved with lorlatinib was 87%, with a median intracranial progression-free survival exceeding 3 years, again speaking to the robust CNS efficacy of lorlatinib. Lorlatinib does have a unique side effect profile. Dr. Shaw, you have treated a lot of patients with lorlatinib and have in its efficacy as well as side effects. Could you please take some time to review the adverse events that we observe in the clinic with lorlatinib?
Yeah, thanks, Jess. I think this is really worth highlighting because lorlatinib does have some unique side effects, and I would say kind of distinguishes it from almost all of our other TKIs. And these are especially related to neurocognitive and mood disturbance. I would say that overall, most of the time, these side effects, so neurocognitive and mood, are mild and manageable. These are dose-dependent toxicities, and I should note they are completely reversible when the drug is held. But I would say that in a fraction of cases, the neurocognitive or the mood side effects can be difficult to manage, and they can even require discontinuation, not just dose reduction, but actually even discontinuation of lorlatinib altogether. And so I think these are really important to be aware of and to counsel patients about before starting on lorlatinib. Then maybe just the few other side effects I'll mention, which are unique with lorlatinib, are the hyperlipidemia. So we often see elevated cholesterol, oftentimes see elevated triglycerides. These you can try to manage with diet, but more often than not, you do need to intervene, typically with a statin-lowering medicine. I would also say that the edema and the weight gain are quite prominent with lorlatinib, more so than with other, I would say, ROS and ALK TKIs. And then also there's side effects related to neuropathy that for some patients can also be bothersome. So I think these are a few overlapping ones, but some very unique ones with lorlatinib that are worth understanding well.
We wanted to underscore using this opportunity that, as you can see, each of the ROS1 inhibitors that we're discussing today has some unique aspects to them, whether it has to do with the side effect profile or dosing and whatnot. So very important to refer to the FDA label and to the trial data whenever using these agents. We spent some time on repotrectinib previously in discussing the ROS1 TKI naive setting. In the same TRIDENT-1 trial, there were cohorts in phase 2 portion of the study that were dedicated to patients who had received 1 or 2 prior ROS1 inhibitors. In the pivotal cohort of patients with ROS1 lung cancer who had received 1 prior ROS1 inhibitor, but no prior chemotherapy, the response rate with repotrectinib was 38%. The progression-free survival, the median progression-free survival in this patient cohort was 9.0 months. And as I noted earlier, activity against ROS1 G2032R mutation is important to consider because it is a common one that we observe in patients at disease progression on crizotinib or entrectinib. Repotrectinib has shown activity against this mutation. In the TRIDENT-1 trial, there were 17 TKI pretreated patients who had a known baseline ROS1 G2032R. And among these patients, the response rate was 59%, and the median progression-free survival was 9.2 months. One aspect that will be helpful to tease out going forward is what the landscape of resistance mechanisms will look like after using a next-generation ROS1 inhibitor like repotrectinib. So I mentioned earlier that repotrectinib has CNS efficacy. In the TKI pretreated cohort as well, CNS activity was observed. The intracranial objective response rate here was 38%, and 12-month intracranial PFS rate was 82%. There are a couple emerging investigational ROS1 inhibitors that we wanted to make sure to review with all of you today, because we're sure that you'll hear more about these in the coming year or two. The first one is called taletrectinib. Taletrectinib is another next-generation ROS1 inhibitor, and this agent was initially studied for patients with ROS1 lung cancer in China. The phase 2 trial conducted in China was called TRUST-1. And in this trial, taletrectinib showed activity in both TKI-naive and crizotinib pretreated patients with ROS1 lung cancer. Among patients who had received prior crizotinib, the objective response rate with taletrectinib in TRUST-1 was 51.5%, and median progression-free survival was 7.6 months. Taletrectinib has shown activity in patients with known ROS1 G2032R resistance mutation in their cancer. Taletrectinib also has shown CNS activity. And so these are all promising efficacy data. And there is a global phase 2 trial called TRUST-2 that is ongoing. And we should see the efficacy and safety data from that TRUST-2 trial reported very soon, I believe. The second emerging ROS1 inhibitor that we wanted to take a moment to review today with you is NVL-520. So NVL-520 is the newest ROS1 inhibitor that we have heard about, now given the name zidesamtinib. Forgive me if I am pronouncing it in the wrong way. So this one is being evaluated in an ongoing global phase 2 trial called ROS1. Patients were heavily pretreated, and the overall response rate that was seen was 48%. Importantly, with responses seen in patients who had received prior lorlatinib or repotrectinib. This is a CNS active agent with activity seen in patients with baseline brain metastases, and it has demonstrated efficacy against a broad spectrum of ROS1 resistance mutations, including G2032R. Of note, NVL-520 was developed to be highly selective against ROS1 and to spare the TRK proteins. Remember, some of the ROS1 inhibitors like entrectinib and repotrectinib also inhibit TRK proteins in addition to ROS1, and that results in dose-limiting toxicities for patients. And so NVL-520 was developed to hopefully improve upon that aspect. Thus far, based on the preliminary safety data that have been presented for NVL-520, it seems to have a very clean toxicity profile, has been very well tolerated. So we are looking forward to seeing the updated data presented.
Thank you, Dr. Lin and Dr. Shaw, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, ROS1 Revealed, a cancer conversation on the changing tide of non-small cell lung cancer treatment, and to download the slide sets associated with this discussion, please click on the link in the show notes. Thanks for listening.